Welcome to the Pacific Research Institute's Next Round podcast. I'm Rowena Ichon, COO, and with me as always is Tim Anaya, Vice President of Marketing and Communications. Tim, a lot's been going on in the policy front in Sacramento this past week. So how about starting off with the governor's announcement of a series of legislative bills, 11 in all, to actually reform CEQA. So listeners know that this is an area where PRI has done a lot of work, and I'm looking at this cheat sheet in front of me thanks to CalMatters. By the way, if listeners don't know about CalMatters, they're a terrific nonpartisan site that reports on California issues. So anyway, I've got this sheet in front of me. Let's go through the governor's proposals on CEQA. First one, the main one being streamlining environmental planning by coordinating among the different local and state and federal agencies. Now, we know this is a problem because there are so many duplicate regulations and regulations that counter one another that it drives a lot of builders and businesses crazy trying to comply with all of them. And I do like this streamlining part of the proposal, but can you imagine the coordination part of it and how that's just got to be a bear? We all know that government turf battles that take place, they often take years to resolve. I would have emphasized less on coordination, but rather wholesale elimination of a lot of these regulations.
That's right. I mean, I think one of the things that, if folks read our great CEQA Gauntlet project that we put out last year, and if you go to pacificresearch.org/CEQA, you can check that out, and you see what we call the CEQA Gauntlet is the map of bureaucracy. And really, any of your thinking on CEQA needs to start with that imagery in your mind, because it's insane the state, local, and federal bureaucracy you have to go through to build anything. And so looking at all of the Newsom bills, you have to kind of ask yourself through that lens, will this cut down this maze of bureaucracy in a reasonable way? One of the things that stood out to me, in hearing the governor's announcement, and A, for effort, I think we welcome all the converts to the cause. I think the big question as always is, will this do anything? Is this the right approach? And it seems to me a little bit of kind of Newsom trying to prioritize initiatives that are key to him. That's why they're kind of in environmental and transportation infrastructure areas. But one of the lessons from our CEQA Gauntlet project that stands out in my mind that the main author of our study, Chris Carr, always cautioned was, we shouldn't really be doing these kind of little fixes around the edges or targeting a particular area, that really we should focus on the wholesale changes to CEQA that are needed to remove these roadblocks and kind of clean up this chart. So projects of every type aren't held up by this unnecessary bureaucracy. I think in that light, the governor's proposals probably fall short. But in the bigger picture, I think any little action in this area is better than no action.
I think this next proposal, which is to limit the amount of time courts have to weigh environmental challenges to just 9 months, I think this is probably the best proposal in this series of proposals. These lawsuits, as you mentioned, that we've detailed in the CEQA Gauntlet study, just takes years and years and hundreds of thousands of dollars to resolve, if they ever get resolved. And many of them, frankly, have very little to do with environmental safety in the environment, and a lot of it has to do with just plain stopping any building. So I think that's the best part of these series of proposals.
Well, also, too, it's a thing that our Dan Kolke has talked about. He's written about, what sorts of CEQA reforms we should do. And, legal reform is certainly part of it. And there are ideas that he's proposed for streamlining the legal process, because it's not just a bureaucracy process. There are a lot of legal roadblocks that hold this up. I think the other thing to think about when you're, assessing the fate of all of these proposals is, if you go and look at our CEQA Gauntlet study, there's a whole appendix that details all the prior failed efforts at CEQA reform that have been attempted over the past, 10 or 15 years. And so, the Sierra Club is already out there guns a-blazing opposing these bills. Is the governor really going to make headway at this kind of late hour in the legislative year to get these through? One of the things that struck me that the governor said in his announcement of these bills was, he wants to have these passed along with the state budget, and he would consider these things called budget trailer bills. And for those of you who are unfamiliar with the process, you pass the main budget bill, and then you pass a whole bunch of what we call trailer bills along with it. And trailer bills are the policy changes that are needed to enact the budget. And so it's in the eye of the beholder. There's a lot of things that aren't really part of the budget that they make part of the budget, because it's a little easier to pass these bills and have them take effect faster, doing it as part of the budget process. But this is already a very contentious budget year between Newsom and the Democratic leadership in the legislature. And I wonder, adding this to the mix, are you really going to get very far when you're already battling over the fundamental issues of, are we going to spend less or more this year?
Well, Tim, that leads me to this budget issue that you brought up, leads me to another part of the proposal, which is to provide additional funding to agencies to speed up reviews and also cut back on the number of documents that each CEQA review requires. Well, I'm a little bit skeptical about this funding part, because as you explain all of the budget issues, but in my mind, just intuitively, more money usually means more bureaucracy. And if you want to speed things up, less is more. So I hope this money is used wisely. But as you say, I think this is a tall order given the $32 billion deficit that we have in our budget.
That's right. I mean, we've commented often about how little oversight and accountability there is in state government. And in a year like this, when we have a deficit, it's more important than ever before that we spend dollars to the fullest.
So, Tim, let's move on to the suspense file. Now, it is a suspense file season where bills go to die. So for listeners who might not be familiar with what a suspense file is all about, how about explaining it and what are some of the highlights of this legislative season?
Sure. So the suspense file essentially is a way that legislators look at every bill that is introduced and passes their policy committee all together in one list based solely on fiscal matters. So basically, there's a lot of programs that are proposed every year. Well, we can't afford all these new programs. So they take a look at every bill in one group in light of their cost, and some move forward, some are killed, some are watered down to reduce their cost. So in a year like this, where there's a deficit, fewer bills that cost a lot are moving forward. It's also been, over the years, kind of an easy way for politically controversial bills that the leadership doesn't want to see move forward. It's an easy way for them to kill a bill without getting their fingers dirty. After the suspense file, all of these bills now go to the floor of the Assembly and Senate. And the next couple of weeks, we're going to have a lot of the heavy bills are going to be getting a vote in their House of Origin in the Assembly or Senate. So it's a really key time. So some of the bills that we've been following, the single payer bill, SB 770 by Senator Scott Wiener, that we've been following all year long. That would be kind of the stepping stone approach to single payer. It's kind of a different way about it. That bill moved forward and with no amendments. So that bill, could be up on the Senate floor for debate any day now. Housing, as I mentioned a little bit ago, there are additional bills to streamline housing that are once again one of the more contentious bills this year. Perhaps the most contentious is SB 423, and that bill moved forward, though there are significant amendments, and there are kind of two issues at play with that issue. So you have the kind of usual debate over conservatives don't like all the dense housing and liberals don't like more people moving into their community. Well, the other issue with this has been a labor issue. Labor unions want to have unions doing all the labor on these projects. Well, one of the hiccups is, A, that adds time and expense to the projects, but B, there aren't enough skilled laborers to do the construction work. It looks like there was a deal with some of the labor unions that hopefully will remove some of the opposition and the bills will have a better chance moving forward. But still, those bills face a very, if history is a judge, those bills face a very uphill battle going forward.
I noticed that there were cash payments to residents of California to help pay for rent and so forth. I noticed that those were all suspended.
Yes, they had $1 billion cost, and a lot of them were involved expanding the earned income tax credit, which in a crude way, is basically using the tax code to hand out welfare payments. Proponents would say it's a great way to reduce child poverty. But those bills were held in committee. There were a lot of bills targeting oil production in California and trying to hold oil producers accountable for supposed health harm and other impacts. A lot of those bills were held. That's the key. A lot of the bills that really cost a lot of money were held. However, even with that, 78% of the bills in the Senate and 71% of the bills in the Assembly move forward. So that means we're going to have probably about 800 to 900 bills that are going to be considered over the next couple of weeks. So still lots of bills moving forward and still lots of new big expenses for Californians if they, succeed in becoming law.
That's right. And folks, we will keep on top of those bills passing and keep you posted on what gets passed, especially a lot of the issues that we've been following. So, Tim, how about introducing the next guest?
So our speaker today, our guest this week, is Bill Smith from the Pioneer Institute. They're a PRI's sister think tank in the state of Massachusetts. And Bill is someone who we've had webinars with before, and he, does a lot of work on healthcare policy and policy specifically related to prescription drug. And as you know, if you've been following the work of our Wayne Weingarten and our Center for Medical Economics and Innovation, we do a lot of work on these policy issues related to prescription drugs, like international pricing indexes and other things that proponents argue would, quote, control the runaway costs of prescription drugs, but actually would limit people's access to prescription drugs, life-saving drugs, and actually have government bureaucrats putting a dollar amount on people's lives. So he has a new book out on this issue, and they are called, an interesting acronym called QALYs, and it stands for Quality Adjusted Life Years. But it's basically an arbitrary dollar amount that government bureaucrats put on a life-saving medication. And in many European countries, it determines whether you get a drug or not. And so we talk through all of these issues and all of the hot debates that we're having now related to prescription drug pricing. So I think you'll find it very interesting. It's a very topical, relevant discussion. And Bill is a really interesting speaker and breaks it down in a very easy to follow way. But Wayne and I had a great discussion with him about all things drug policy.
Thanks so much, Tim. And thanks everyone for listening.
Bill, welcome to PRI's Next Round podcast.
Tim, thank you very kindly for having me.
So you've written an important book called Rationing Medicine that focuses on an obscure yet very important economic concept that's harming millions of Americans. And the concept is called cost effectiveness reviews that typically rely on a metric called the Quality Adjusted Life Year, or QALY. So let's start with some basics. What are these concepts and what is their purpose?
So the Quality Adjusted Life Year is a cost-effective methodology that developed in Europe. First, it was invented at the University of York in Great Britain. And, the cynic in me would say the reason these cost-effectiveness reviews surfaced is because the politicians in countries that have socialized medicines do not like making decisions about which medicines to make available for their populations. In the US, there are so many different health plans. There are government health plans, commercial health plans, Medicaid, Medicare. There's no one bureaucrat anywhere who can make a decision about who gets exactly a new medicine when it comes out. But that's not the case in many European countries, especially Great Britain. The National Health Service makes the decision when a new drug is approved. Is it made available or is it not made available? And there's some stories from the 1990s where they came to the health minister, a guy named John Major's health minister, and they were trying to decide about whether to make a multiple sclerosis drug available. It was a new drug, and the MS community had great hopes for it. And they couldn't decide what to do because it was going to be very costly for the National Health Service. And wheelchaired people with MS descended upon the parliament, created an enormous political firestorm, and the health minister ended up partially approving it for some part of the MS population. But he said to his staff on the way out, importantly, don't ever put me in this situation again. Don't ever make me make a decision like this. We need a bureaucracy that's somehow going to make this decision so we are shielded from it, he said in so many words. And hence, they develop these cost effectiveness bureaucracies in many of these countries. And, the methodology is relatively straightforward. It's more complicated than I will describe. But basically, what they do is the QALY decides the value of a drug based on two poles of value. How long does it increase the patient's life, longevity, and how much does it improve the quality of life? So quality of life. So a new drug comes along and they'll rate it. So say a new cancer drug comes along and it gives 6 months of life, not a full year, but 6 months. It will get a 0.5 QALY score out of 1. Let's say that drug also has some side effects. So it doesn't get a very good quality of life score. It gets a 0.3. So you got a 0.5 and a 0.3, and that's averaged out to a 0.4. It ends up, this drug gets a 0.4 score. Then they assign the value of a human life for 1 year. And they say, okay, the value of a human life, say in the US, CVS rated the value of human life as worth $100,000. So a human life lived for a year in good health, good quality of life is worth $100,000. So if you multiply the 0.4 score for this particular cancer drug times 100,000, you get a $40,000 threshold. So if the drug is less than 40,000, it's rated as cost effective. If the drug is more than 40,000, it's rated as not cost effective. But the most striking thing, and I'll let you go to the next question, but the most striking thing about this is it's completely subjective because the $100,000 assignment of that value of life is completely arbitrary. I mean, who comes up with that? Who decides what's worth 100,000? Or if I'd say if it were one of my kids, it'd be 100 million. And then any drug would be rated as cost effective if it were 100 million. So there's a kind of subjectivity to the QALY. And, the bureaucracies can move that value of human life up and down and decide how many drugs are going to get approved each year. It's a way of them controlling costs and saying, we have an objective methodology for rating the value of drugs, and we're not making these decisions based on politics or budget or any of those things. We're using an objective methodology.
When what you were just talking about, the QALYs declaring the value of a medicine, because that has generated a lot of controversy. Could you overview the criticisms of the QALY? In your opinion, does the QALY methodology accurately determine the value that medicines provide patients?
Well, Wayne, the problem I have with the QALY is that it's kind of an abstract standard, right? We're going to measure longevity and we're going to measure quality of life. Fine. Okay. That sounds commonsensical. If a drug makes you live longer and live better, maybe it should be rated at a higher value. But when you get into the particulars of different types of patients, the abstract nature of this QALY breaks down and you get all sorts of perverse conclusions. So, for example, they with cancer drugs, they look at the clinical trials for a cancer drug and they decide, okay, well, how long did this increase life and how did it increase quality of life in the clinical trials? Well, it turns out in cancer clinical trials, the cancer you're testing it on, say you're testing it on lung cancer, ends up not being the cancer that the drug is used on because oncologists experiment and they discover, hey, wait, this lung cancer drug works better on prostate cancer, increases life longer, increases the quality of life of a prostate cancer patient. And so there's a lot of experimentation and the clinical trial data is not that valuable. And if they're looking at longevity and quality of life in the clinical trials for an oncology trial, they're looking at the wrong data. And there are all sorts of other anomalies like that. For example, with elderly people, they have fewer QALYs to give, right? So, if a drug is not going to make an 80-year-old live 50 more years, but might make a 30-year-old live 50 more years. So the QALY has a bias towards drugs for younger people because they're more highly rated. They provide more life years. Same problem exists on the quality of life side for people living with disabilities. Many people living with disabilities, if a drug comes along that increases their life 25 years, but does not get them out of the wheelchair, it's going to get a high longevity score, but it's going to get a low quality of life score. And so by its nature, drugs that treat the community of people living with disabilities are going to be lower rated than others. So there's all sorts of anomalies and problems and perversions in the QALY that apply when you go in and look at actual patients and how it's applied to them.
So kind of following up on that, as you mentioned, the QALY discounts the benefits that medicines provide certain groups of people, including older Americans, the disabled, and people living with pain. So in your view, what are the implications for these groups from this fact?
Well, you never want to find yourself in a socialized medicine program or plan where they're using the QALY to rate the value of your drugs if you're in one of these patient populations. And we may talk later about rare diseases, but that's another area where the quality is very infirm in rating the value of these new therapies. And if I were a senior citizen, for example, and I was on Medicare and I got my drugs through Medicare, I would not want any bureaucrats in Washington using the QALY to decide which drugs would be made available to me.
If we can pick up on rare diseases that you just mentioned, because that's one of the more exciting developments in healthcare, right? Is this development of orphan drugs that are treating people with rare diseases. And rare diseases are conditions for our listeners that afflict 200,000 people or less. So could you explain why QALYs are posing a threat to people living with rare diseases?
Yes, it goes back to what I explained before about how they assign a value to a human life lived in good health for 1 year. And in the U.S., the QALY Institute here is called the Institute for Clinical and Economic Review. And they rate the value of a human life lived in good health for 1 year as between $100,000 and $150,000. And if anybody understands the economics of biotech, in particular, biotech companies, there are many rare disease drugs where you spend an enormous sum on R&D, and then the drug comes to market and you only have 2,000 patients that you're treating. And, we can argue about individual cases of drugs that might be too expensive, may have been priced too high, cost $3 million, which shocks people's conscience. But at the end of the day, rare disease drugs are going to be more expensive because they have fewer customers to sell them to. And the QALY doesn't seem to take that into account. And so many of the reviews on rare disease drugs that have been done have rated them as not cost effective. And it has to do with this economic problem, the economics of rare diseases and orphan diseases. And this is a real problem because for the last couple of years, the FDA has approved more orphan drugs, meaning, as you said, orphan drugs are for patient populations of less than 200,000. The FDA has approved more orphan drugs than non-orphan drugs. So if there's a bias in the people rating the value of those, you have a problem.
So in your book, you note that the UK Price Control Board, which is known as the National Institute for Health and Care Excellence, or NICE, relies on the QALY methodology. Here in the US, the Institute for Clinical and Economic Review, or ICER, we'll have a test on these acronyms later, has decided that it should serve the same role as NICE, albeit without the official imprimatur. So what is ICER, and why, in your view, should people be concerned?
Yeah, so my concern about ICER is if they were to worm their way in to be the cost effectiveness referee for government programs, especially Medicaid and Medicare, because for many senior citizens or lower income people, those are health plans of last resort. They can't go anywhere else. If you work for a big employer, you have 2 or 3 plans you can choose in an open season, you can switch. If you're a Medicaid patient, you can't do that. And if you're a Medicare patient, you can't do that. So if ICER were to find their way into the government and become the referee on deciding whether therapies were valuable or not valuable, people would have no place to go. So if they degraded the formulary and suddenly low quality drugs were available, but not high quality drugs, where would you turn? Where would you turn if you were a Medicaid patient? And you'd have no choice. At least people in commercial health plans can vote with their feet and potentially sign up for another plan. And I also think in the commercial health world, commercial health insurance companies have a market-based incentive to keep a quality formulary, to make quality drugs available, because they want to be able to go to employers and employees and unions and say, hey, we have a quality formulary. Sign up for our plan. The same incentives don't exist in the government plan. So the ICER worries me most if they were to worm their way into the government and become the referee on deciding the value of therapies.
So one of the more troubling aspects of ICER's analyses is their unwillingness to incorporate the broader benefits from medicine into their studies, right? So the benefits from a better cancer drug, for instance, are going to go well beyond just the health impact and the direct medical cost for the patient. So could you talk about what some of these broader benefits are and what does their exclusion from ICER's consideration mean for patients who are living with these devastating diseases?
Yeah, that's a very good question. And there are very important, valuable things that drug therapies can solve that they don't take into consideration when they calculate the value. So, for example, there are peer-reviewed studies that indicate that patients with cancer get an average of 33 hours per week in caregiving from a relative, a spouse, a friend. They need a lot of help. They need shopping. They need sometimes to be showered. They need people to clean their house. If they can't get out of bed, that's a big problem. You got to have some intensive caregiving. And I've had that situation with my own relatives. And, if a drug comes along and suddenly it gets that cancer patient out of bed, that cancer patient can go to the supermarket, that patient can cook their own meals, suddenly the caregiver is freed up, may be able to go back to work for a little or part-time, or that value is not captured in the ICER QALY reviews. And that's an important value. And more broadly, for example, everyone knows that the life expectancy, although it's declined recently with COVID, life expectancy has grown tremendously over the last 50 years. So people are living, people that used to die in their early 50s are living into their 80s. Now, what is the economic value of a senior citizen who can work at age 52 to age 70, 18 years of valuable, productive employment because they've got some kind of drug therapy that's kept them healthy? That kind of thing is not captured by the QALY methodology. So the QALY methodology has all these shortcomings, and I don't want it to be used, particularly in government programs.
So personalized medicine, as we know, is revolutionizing care and helping patients overcome illnesses that might otherwise be terminal. From a patient perspective, these advances are very exciting, but you argue in your book that ICER and its cost-effectiveness evaluations threaten to deny too many patients the benefits that personalized medicine offers. So could you explain why and also what this means for patients' health?
Yes, and it's my firm belief that personalized medicine, particularly our knowledge of genetics, is going to make these types of cost-effectiveness reviews like QALY obsolete. Because, for example, if you're diagnosed with lung cancer these days, you're not diagnosed with lung cancer. You're diagnosed with a very specific genetic type of lung cancer, and there are a variety of types. And therefore, therapies that are going to work on you may not work on 70% of the other patients with lung cancer. So if you're just doing a study of a drug where they put everybody with lung cancer into it, the ICER methodology and the QALY methodology is not going to capture the value of that medicine, because for some, it's going to be highly effective. It would get a very high QALY score for those patients with certain genetic predispositions. And for others, it wouldn't get such a high score. And I'm not sure you want to have averages for things like this, because it's not about the average drug, how the average drug works on the average lung cancer patient. It's about how an effective targeted gene therapy or genetically disposed drug works on a particular type of lung cancer. And I think these broad-based cost-effectiveness reviews where they use a large amount of patient data, I just think they're going to be obsolete as we learn more and more about the human genome and the genetic origins of diseases.
Speaking a lot about the problems that are inherent in the QALY in particular, but also cost-effective analyses more broadly. So what should politicians at the federal and state level do to protect patients' access to innovative drugs?
Well, the first thing I would do is I'd ban the use of the QALY in government programs. And there's a bill on Capitol Hill now. It's being sponsored by Kathy McMorris Rogers, who's the chair of the Energy and Commerce Committee in the House. The bill has already passed the subcommittee on health at Energy and Commerce and has passed the full committee, and may go to the House floor any day now. And it basically says you cannot use the QALY when you're rating the value of therapies in government programs. That's the simplest and most straightforward way to get rid of the QALY in American government programs. And I find it refreshing that American politicians are actually, for the first time, wanting to take power out of their own hands, because the QALY puts the power into the hands of government bureaucrats. And this bill on Capitol Hill would actually take it out of the hands of the bureaucrats and say, nope, you can't use this.
So finally, as we close, we call our podcast Next Round because of PRI's proximity to wine country and our love of discussing public policy while enjoying a great glass of Napa wine. So what beer, wine, cocktail, or other other beverage are you enjoying to celebrate the publication of your new book?
Well, Tim, that's a great question. And I think it's situational. Let me just put it that way. If you find me on the Long Island Sound with my buddy on a boat, it'd probably be Silver Bullets, Coors Lights in a cooler. If I'm with my wife, who has much more refined background and pedigree than I do, it's probably a French white like a Sancerre. Or if it's a red, it would be a California red, like a big Zinfandel, a Turley Zinfandel, a Ridge Zinfandel. I like big wines, and Napa makes some great red Zinfandels.
Bill, thanks so much for joining us.
You bet. My pleasure. Thanks for having me.
If you like this episode, please tell your friends and subscribe to PRI's podcast at iTunes, Google Play, Stitcher, TuneIn, iHeartRadio, and Spotify. And when you're on these platforms, don't forget to give us a big 5 stars. If you don't subscribe to any of these, you can still listen on PRI's YouTube page, youtube.com/Pacific Research 1. That's the number 1. Thanks for listening. I'm Rowena Itchon. Hope you'll come back again for next round with PRI.